I'd like to welcome everybody. Hi, I'm Steve Campbell with Marketing and Communications, and just wanted to invite everybody to the second of the series of Mondays in March. Last week we had a great panel that discussed the case for growth. If you weren't able to be here in the auditorium or accompanying us by streaming, if you go to UTMB, there's a link on the homepage. Go into the Mondays in March site. I'd encourage you to go and watch the recording and watch the video. There was a lot of really good information in there that I think everybody would be interested in. Also, as a reminder, next week we have the third in the series, same time, same place, and that topic will be on the academic foundation, and we'll include a discussion on how we're leading change in education and how we're prioritizing and investing in research. I am going to make one plug before we introduce the panel. Last week we talked about Stat Madness, which is an online journal that publishes a lot of science and education, a lot of science research. And they're doing a March Madness, just like the basketball brackets. We made it through the first 64. We're now in the final 32. So there's a link on the homepage of UTMB. Please go out and vote. The research that we have out there is on growth of lungs in the lab. And so vote early and vote often. And let's see if we can get down to the next bracket. With that, I would like to introduce this week's topic is healthcare, evolution or revolution. The panel this week is led by moderator Ms. Donna Sollenberger, Executive Vice President and CEO of the UTMB Health System, Dr. David Marshall, System Chief Nursing and Patient Care Services Executive, Ms. Katrina Lambrecht, Vice President of Health System Operations in Regional Hospitals, Ms. Ann O'Connell, Vice President of Ambulatory Operations, and Dr. Gulshan Sharma, Vice President, Chief Medical and Clinical Innovations Officer. With that, Donna, I'll turn it over to you.
Well, first of all, thank you to everybody who is here or who will watch the recorded version of this, as well as anyone who is streaming. Although I suspect by the size of the audience, spring break is upon us. And so thank you, especially all of you who came out today and who came to work today despite it being spring break. We appreciate you. This is a really great topic. We have met a couple of times just to talk through some of the things that we might talk about as we think about, is healthcare in an evolution or a revolution? Where are we in this? But I thought I would open the conversation that we're going to have today among us with some statistics, which is why I have this little clipboard so I can see all of them. But the Kaiser Foundation and the Episcopal Health Foundation within the last year decided to do a study to find out Texans' views on healthcare priorities at the state and national level. And I thought I'd share some of those with you because it shows you how front of mind healthcare is for so many people, and especially gives you some sense of what Texans are thinking. They say it's the highest priority behind public education funding, equal to public safety and infrastructure. Patients want initiatives that will lower the cost of health care and prescription drugs, reduce infant mortality, improve access to health insurance, and provide funding for mental health patients and programs. 2/3 of Texans say state government is not doing enough to assure low-income adults get the health care that they need and want, and that the Medicaid program should be expanded. And the one that really troubles me the most is Texas remains the uninsured capital of the nation. Some other statistics that were kind of interesting. Healthcare affordability, of course, is on everybody's mind. 1 in 4 of the people surveyed said they had problems paying their medical bills last year, and 1 in 6 say they deferred getting healthcare they felt they needed because they couldn't afford it. On access, this was interesting. I know Ann and so many people work on that. 1/4 of Texans say they don't have a usual place they go to get their health care, or they rely on emergency rooms for that. And the number of people using emergency rooms for their regular care rises to half if we're looking at the non-elderly uninsured. The respondents to the survey also said we need to address chronic disease epidemics like diabetes, CHF, chronic heart failure, obesity, and that we must address some of the social determinants of health that include transportation, food, adequate housing, security, and nutrition. And then the last item that I took from the survey that I thought was really interesting is the respondents said they need to have what's being done for them explained in terms they can understand. So they need to be educated, need more healthcare literacy. So in that context, we start thinking about, is healthcare, does it need an evolution or a revolution? Not just where are we? So I thought that several of us up here today have had years of experience in healthcare. We won't say how many. Yet many of these problems, I think about when I started out, are the same problems that were there when I was a young administrator. So, Dr. Marshall, David, why is it we seem unable to truly have a revolution in healthcare, or do we need a revolution at all?
I think we probably need a revolution. What historians tell us when they look at the last 150 years is there's a revolution in healthcare about every 50 years. In the 1870s, germ theory became predominant, and surgical practices and anesthesia practice became predominant. 50 years later, 1920s, penicillin was discovered, led to a revolution in medication use for disease treatment. And then in the 1970s, randomized controlled trials came about, and that led to what we have now as evidence-based practice. So we're right on the cusp of moving into the 2020s. 50 years later, and I think we're primed for a revolution. I don't know if we can cause the revolution, but I think there are several trends that we've been looking at UTMB that point to a coming revolution. I've been in healthcare for 3 decades, and when I first came in, DRGs was just becoming prominent in the payment system. I think price frustration is something that's going to drive a revolution in healthcare. And that is probably part of consumerism. Consumers become more and more responsible for their co-pays and their part of paying for health care as employers look to decrease their cost that they're paying. I think other parts of consumerism that are going to probably be the trends that drive a revolution will be, we don't rely on our providers to give us health information like we used to. We turn to the internet and things that are available online. I saw a billboard the other day that said, "Don't equate your internet search to my medical degree." But, you know, I think consumers largely look, that's the first place they go when they have a symptom, is they Google it and say, what's going on? So I think consumerism from those two aspects is going to drive probably a revolution in healthcare. Other things are data. Healthcare creates tons of data, and we're just now starting to use big data and research, and UTMB has embarked on using data through UTMB Discover, and I think we are going to start probably using data to improve care at a more micro level than some of the big data may be used for, but we may be able to improve in cardiology practices or smaller areas where we have tremendous amounts of data, but we can now, with the tools that we've invested in, use it to improve the care of our patients. I think the other trend that I would mention is the trend towards value in healthcare. And right now, we seem to be trying to wring value out of caring for sick people. But what does the future hold? Are we going to try to create value by engaging people to take care of their own health in the future? I think that's a trend that we need to stay focused on. And, you know, population health is part of that in the future, I think. But population health is probably just scratching the surface on engaging patients to be involved in their own healthcare and making themselves healthier.
You mentioned, David, the use of data to help us think about how do we care for patients, and we do have a really great example of how we've been able to invest through the UTMB Discover platform and creation of our UTMB Health Population Metrics app, which is really the app that we're using to get real-time updated daily data to look at our disparate populations. So with this new version of the 1115 waiver, our payments are really now more value-based because they're based strictly on the outcomes of this set of metrics that we need to perform on. And what we have seen through the implementation of this tool is that we really do have the ability to prioritize the work that we do to see which patients are most at risk, find out where their gaps in care are, and be a lot more proactive in trying to manage the population of patients. Now for DSRIP, it's the Medicaid low-income uninsured patient population, but you can apply that to other patient populations as well. And I think it's given us a really great tool to begin to utilize our data in more robust ways as we think about managing populations rather than managing sick people inside our four walls.
So I feel like, all healthcare is local. So healthcare has evolved over a period of time, but you can have a revolution locally. So let me explain what I meant. So Tour is Human was published by Institute of Medicine in 1999 to actually show the quality and patient safety in United States. So they started this journey of quality and patient safety 20 years ago. 20 years ago. And we are still debating which quality metrics to use.
That's right.
So healthcare at a Washington, D.C. level is going to evolve. However, we can revolutionize healthcare locally on things that are pain points to us. So I would say or submit to you guys, so the things that we did in Best Care is revolutionary locally for us. Because we were ranking 76 and we worked hard as a team and we moved to number 9. Even though the quality and patient safety debate has been going on for 20 years nationally. And now, value proposition came after Affordable Care Act. So value is about 10 years old. Okay, so the key is, there are 3 main players in the value proposition: employee, you all, or we all, employer, UTMB, and the payer, Blue Cross Blue Shield, for us. So for all of this, there's a different value proposition. So most of debate currently is at payer and employer level for value proposition. And only way we're going to get to value when we all who provide frontline care understands that. So I gave an example during my Best Care talk. In 2015, 4 of us, me, my wife, and 2 kids, UTMB paid $860 per month per paycheck for our insurance. We paid $360. 2019, UTMB paid $1,160, and my share was $560. 30% increase in our insurance plan alone in the last 5 years. I think Cheryl mentioned on that day that we actually, in our budget, we put 2% increase in expenses. So you think how big of an expense is just an insurance plan. Now, payers are not evil, okay? So they want to make sure they provide the proper health care and get the right quality on the right cost. So Blue Cross Blue Shield currently spend $440 per member per month. So they would say, okay, you guys actually cut your cost if you can, provide the quality. Our estimation is we would spend $460 per member per month next year. So if you guys cut the cost to $450, we will split $10 with you. That's the simplest way of looking at it. The only way we can do that if we actually handle our cost of care. That is in our hand. So we need to understand what is appropriate and necessary and where we provide the care to our patients, inpatient, outpatient. I think that will really help to actually revolutionize how we provide care at UTMB.
I think that we have missed out in many ways by leaving our patients out of this equation. And I think that if you were to interview one of our patients, they might say that quality is about whether or not they get access to the appointment that they want today or tomorrow. I think that the quality would maybe not be the way we define it. Our patients, I think, are hungry for us to realize that we are serving 5 generations of patients. The Generation Z, those born after 1996, what kind of access do you think they want? Immediate, right? They will accept no less. They don't even want to talk to us, right? They want to manage their health care from their telephone. They want to do it digitally. They do not want to wait on a phone tree. So what have we done to reach out to this generation? And conversely, we have an older generation. And those are the patients who really do want to call us. They want a live person answering the phone, and they want to have an ongoing longitudinal relationship with 1 or 2 providers, not a bunch, right? And they get very upset when their providers leave. So we have all of these generations that we have to cross and use technology, right, to bring about the revolution that is needed to serve these 5 generations. And I will tell you now, I'm a baby boomer, and I am very impatient with having to wait for an appointment, having to wait in the reception area for an hour and a half, or 45 minutes, or 10 minutes. I am very impatient when I'm told that I have to wait for the referral to be processed. Why can't I just self-refer? And I'm very impatient when I'm standing at Walgreens waiting on a prescription. So I think that we have to meet our patients, all 5 generations, where they are. When we first encounter them, we have to ask them, how do you want us to communicate with you? Do you want a live person to call you? Do you want a text message? Would you like to receive an appointment reminder by MyChart? Are you aware that you can do open and direct scheduling through MyChart? Or is that enough? I would offer to you that those things are not enough. Why? Because for open scheduling and direct scheduling, not all clinics, not all departments even allow this. So we're way behind in listening to our patients, understanding what their needs are, and designing systems around that. And I'm as much to fault as some of you in the room, right? We have become casual in our approach to the way we provide care. I was struck in a meeting last week where we were sitting and designing waiting room space. Why are we doing that? Right? We are intentionally building 2.5 seats for every exam room. When are we going to stop that? And be ready for the patient when they arrive, and the team has already looked at the chart, and the team is ready to go. And Ms. O'Connell, you can just go ahead and go on back to exam room number 12. You can use your boarding pass to scan in, and we're ready for you. We've been waiting for you. We're not there.
Those are all really great thoughts. I was thinking back to when I started, and it was even earlier than you, David, by at least a decade. But, you know, we've changed so much of our care. Everything used to be in inpatient. I mean, there wasn't, you went to the outpatient clinic to see your doctor, but really everything else was done at the hospital. And you didn't really visit the doctor all that much. And sometimes, actually, I'm so old, I remember a doctor visiting our house one time. And that was really nice for a young mother, my mom at the time, with 3 young kids and one that was really sick. And so it was either they came there or she bundled everybody up and took them to the doctor. So, times have changed, but as we think forward, especially, I'd be interested in Gulshan's thoughts and anybody's around how do we see UTMB being involved in and trying to lead the way in some of the change that needs to occur in how we deliver care.
It's true. I don't think patients want to be in the hospital. I don't think patients want to go to the emergency department. I don't think they necessarily want to come to the clinic every time we force them to come to the clinic Monday through Friday from 8 to 5. We have not made care convenient, right? We have not created care on the patient's terms. I think that we have to stop making excuses. And I think that we have deluded ourselves into believing that healthcare happens in the hospital, the ED, urgent care, or the clinic. That's not true. It's never been true. Healthcare happens in the patient's home when they decide to follow the diet that we have prescribed, or whether or not they have the medication that they need, or whether or not they have the money to buy the medication. Do they have money for their insulin? We believe that we are the orchestrators of all of this, when in fact, it's actually the patient behind closed doors at home in their family environment that's really going to drive healthcare in the future. One of the fastest growing jobs on the market is what? Home health and home health aides, right? Why is that? Because more and more patients do not want to come into our facilities. Our facilities are seen sometimes as barriers, especially for patients who have disabilities, who can't navigate our large campuses, who can't do steps. We don't have appropriate ramps. We don't have the right language or the right interpreter. So they want to really stay home, and they want us to figure out a way to provide that care to them in their setting in a way that they want to receive it. It's a conundrum for me, but I'm hoping that we can begin to turn the ship and begin to think about our patients in their home settings, how we can use technology to monitor their blood pressure, monitor their weight, monitor their hemoglobin A1Cs, give them calls from our offices and applaud them for doing a good job, or remind them to take their Lasix. This is where I think that we need to head.
I think you're totally right, Ian, and I wonder about the way that we prepare nurses today. We prepare them mostly in a hospital-centric way. They do get some exposure to non-hospital care, but preparing the future workforce to work outside the hospital walls, as you discussed, I think is very important, especially as 80 million of us are going to join the Medicare rolls in the next 15 years. How will those 80 million be cared for, where they want to be cared for? I think CMS is preparing for this by last week announcing that there could be non-transport EMS where people could decide to get their care from the EMS provider. How will we prepare to do that? And are the people that we currently have in the workforce able to retool to be able to do care outside the hospital? If you look at some of the predictions for the future, they say that we may be preparing externalists instead of hospitalists to take care of patients in the external environment, and that hospitalization may occur in the home, and that hospitals may just become large critical care units.
I think that's a good point, David, when you think about how do we think about the workforce in caring for our populations. It's not just are we training the workforce in the right way, but are we using the workforce we have in the right way? And as we think about more of the care of patients, as it always has been, but how do we think about impacting their care outside of the time that they are face-to-face in front of us? I think we have some early successes with things like the ACO-like contracts we have with some of our payers that are helping us to develop that infrastructure around things like the health maintenance team that does make outgoing calls to help patients be reminded that they have preventive screenings that they need to take care of, and how can we help you take care of those. And really being much more proactive with our patient populations to help them understand the things that keep them well, rather than we are here to care for you when you're sick. And I think to touch on a point that Dr. Sharma made earlier, all of those things have to happen at sort of that local level, right? When we look at data across the institution on how we're performing for a given patient population, that data helps us drive down to a very localized level so that a given provider or care team can look at the performance of their patient population and see, well, this is what I need to focus on in my clinic. And we have some great examples of that where maybe it's a physician champion or it's an MA that really does make the difference in that local clinic in terms of how do I improve performance for my patients on, say, upper respiratory infections? How do I help our patients think about staying healthy? How do we think about the team overall so that we don't depend on the physician only to really catch those things, because that's not really the most effective use of our workforce.
You know, David, I was just thinking, keying off of what Katrina said, effectively using our workforce. We know that as we go forward, we've had to do a lot in terms of trying to correct our costs of caring for patients. And one of the things that we have been exploring, you've been exploring in nursing, are some ways that we might alternatively provide care without the nurse having to walk into the room every time, or run from one end to the other. And I think that's where, as I think about how can UTMB lead the way, one is to really start embracing some of the technologies that could help us with our workforce issues, but also help us with what Ann said, some of the technology applications we could do that would allow us to extend our reach beyond a clinic or beyond a hospital. So do you want to comment on some of the
Yes.
ways we're trying to lead the way?
So one way that we're trying to lead the way is looking at a virtual care platform where a nurse can be spread over more patients through the television in the patient's hospital room or their home, and they can cover more patients through that sort of telemedicine but virtual nursing presence. Another way that you've probably seen in the press recently is our exploration of using a robot to support nurses and take tasks that nurses don't necessarily need to be doing away from nurses and let the robot do them. We had a pilot with Moxie, that was the name of the robot, at UTMB a few weeks ago. Moxie was here for about a month and worked at about 25%. They estimate Moxie worked at 25% of its capacity. But on a daily basis, the tasks that were taken away from nurses, they calculated about 3.3 hours a day was given back to staff so that they could spend that time with patients from the 25% productivity that Moxie was doing to pick up tasks. So Moxie carried soiled linen to the linen room, brought admission kits to the room to prepare for patients that were going to be arriving so that nurses wouldn't have to go to the storeroom and pick those up, or nursing assistants or patient care techs. So Donna's really supported us being creative and innovative and thinking about the future and how we may meet the needs of the patients that UTMB serves when there's a projected workforce shortage and we may not have enough people to go around to do care that we do the way that we do it today. So those are a couple of the things we've explored.
One of the things you talked about earlier was we've done some revolutionary work around best care, and we've really done that locally. I guess I'd like to have you talk a little bit about why that work was so important and why continuing to perform well there is going to be really relevant for the future.
You know, I think about yourself as a patient. You know, Donna always give an example about, you know, if somebody asks you what kind of care you provide, that it's okay. You know, so we want to provide the best care possible at this institution, and I think we do. And we need to continue to look at opportunities. I think one of the single most important quality measure is actually length of stay. Now let me explain to you, because we talked about mortality safety. If the length of stay is low, that means you have a very efficient system that you are putting your patient through properly through a system. The second thing, you didn't cause any complication during that hospital stay. That's why the length of stay is shorter. So I think the single measure to look at, even though we look at all the measure, is focus on length of stay and see how it is progressing. In any unit, in any area, that is a true measure of whether we have a well-greased system and we providing quality care. And that's what we will be focusing on, and also focusing on safety as such, that a culture of safety within the organization. Now, the next thing would be, because we are measured, even though you look at Vizient, you look at US News, you look at Leapfrog, they're all trying to measure. I was actually making another PowerPoint for development board, and I actually put a slide of Cub Scout badges. My son was a Cub Scout. It's like everybody wants to have a badge, but you try to figure it out what badges matters. Okay? And I was looking at IBM Watson. They are running a 100 hospital, which was old Truven. You know what one qualification to be a Truven or an IBM Watson 100 hospital is? You have to have a 10.6% your net profit. We will never be in that market. You know, we are not a private hospital. So what we need to look at, what matters to our population, what matters to the population we serve, and true to them, and continue to progress. The second piece which we are focusing on is high value, and I'm passionate about high value. I think the old times as an internist, which I was, we could run all gamuts of tests. Patient came in GI bleed, we got a CT abdomen, now the patient had a renal mass, now we want to go ahead and biopsy the mass, and now, long and behold, patient got a complication and realized that we shouldn't be doing any of that. Patient came in with GI bleed, we focus on GI bleed, and then everything else can be done as an outpatient after the acute issues are resolved. And that's where we need to change the mindset of our provider. We got to provide what is appropriate, necessary to take care of those patients when they walk into the hospital. Most of the stuff is now drive-by. You can get a PCI drive-by. You can get a knee joint now drive-by.
That's right.
You know, because, you know, it is good for patients, because hospitals are not great place to be. Okay, we all work here. So we need to provide care where we think it is appropriate and best for our patients.
I want to say a few words about where I think that we can improve things in our clinics. I think the future in our clinics is all about teams, and I look at how hard our physicians and providers are working, and I think about that they are doing data entry, and it bothers me. They're also doing tasks that I don't think that they necessarily should be doing. So why are we allowing our physicians to do the tasks that an APP can do? Why are we allowing our APPs to do the work that a registered nurse can do? Why are we allowing the registered nurse to do the work that an MA can do, and on and on? It is time to reset the teams. I believe that our physicians could see more patients in a more quality way if we had our teams working at their optimum skill level, pushing it right to the upper edges of your competency, of your skill. And we're not doing that. We're kind of in this medical office mode of, I room the patient, the physician has to do everything else, and I don't really, I can do medication reconciliation, but I'm not comfortable with it. We've got to push past some of this. Dr. McCullum and I are working on a project right now to reinvent the clinical roles of the staff within the clinic and the role of the PSS, because I think it's sorely needed. I think our physicians and our providers need a lot of help because our patients are more complex. And there are a lot of things that we can be doing to tee that care up so that the physician then becomes, if you will, the consultant in the formula. I would offer to you that they should be the consultant. They should be the director of the medical care, but then the team is out obtaining the data and the information and doing all they can to make that visit as easy for the patient and as easy for the provider as possible. I also think that we need to break away from this one-to-one visit. One patient, one doctor. One patient, one provider. Many organizations years ago have been doing group visits, right? That's been around a long time. We also know of organizations that are willing to see 5 children in a visit at the same time, yet we're reluctant to do that. Donna mentioned that, there used to be a doc that came to the home and probably saw everyone in the home, not just one child. So some of what is innovative and futuristic, I think, is also old school and basic, and we need to get back to it. If there is a family that has 5 children that need to be seen, I think we should offer that service, right? So having the team really seasoned and retrained. I know some of you are smiling like, Ann, I wish you had done this years ago. And we still need to do this work together, but I think this is the answer. Do we need more staff to do that? Maybe. Do we need to repurpose some of the staff that we have now, taking funds and resources away from one thing and funding something else? Absolutely. I think that we've got to push the reset button on what I would call teams. I don't think that we will get through the next decade unless we work in a team-based way.
So one of the things I was thinking about just hearing all of this back and forth is I've heard a lot of good general ideas. And I'm going to put my team on the spot because we met once to kind of talk about what we might discuss, and this wasn't really on it. But as I hear this, I begin to wonder, do we have so many good ideas? And we talk about those great ideas, but how do we get to something happening? How do we get to things that actually happen, that matter, that change the way we care for a patient, that changes the way we deploy our staff? A lot of you in here are, with the rest of us, working to open the Clear Lake Hospital. We're getting, ready for the budget, where we should have already thought about what of these ideas we really want to move forward with. So tell me a little bit about, and I'm going to put David on the spot, in nursing. You talked a little bit about Moxie and virtual nurse, but some of the things you're doing, thinking about how you deploy people, train people, make some decisions around what you're going to do, so we get beyond talking about what's great to do, and we actually start making it more of a difference, because we make a big difference every day.
So when I think about the future, I think that we have to be grounded in the past, we have to take care of what's in front of us, and we have to be cognizant of what's going on in the world. And I don't think we could sit up here and talk about revolution without at least mentioning Amazon, Berkshire Hathaway, and JP Morgan Chase trying to make care cheaper, more efficient for their employees. And I think last week they named themselves Haven, which to me means sort of safety, I guess. But what are we doing? Well, we're respecting the past. We're really great admirers of the past around here, and we try to do the things the way we've always done them. And we're taking care of what's in front of us. It's more and more challenging every day. It's a really busy day in the clinical area today. The operational tempo is really high. And people rally around that, and we get things done, especially when it's spring break and everybody wants to be off, and we still have to take care of patients. And then the eye toward the future. I think the future for us is going to require more experimentation. We've had to experiment with submodels and different models of care and how we're going to meet needs. But we have to free people up to do that experimentation. You can't be taking care of the business in front of you while you're also trying to figure out the future. I don't think. You have to have a little time to think about how you're going to meet patients' needs in the future and what the external forces are that are affecting that.
Yeah, so I think it's okay to fail. And I think as long as you learn something from that, I think it's okay. The failure is if you don't learn from your failure. So I think what we discussed is within our group, so there are a lot of good ideas. So we're going to start thinking about how to pilot one good idea that we think that we want to provide good patient care or good services in coming future, and learn from it and see how we want to improve upon it. And I agree with you all. I think there are plenty of ideas. This is nothing revolutionary. You go to different market in East Coast or West Coast or other areas, they have done all these things. The reason is their payers are very different. Their budget is very different. How the fund flows are very different. So we can't do it full Monty that let's tomorrow starts having video conferences and do not have any exam rooms and all that stuff. We have to understand what population we serve, and I think we are almost 10 years out of Ike, and we have rebuilt, we have nice growth plan, and I think it's the right time for us now start investing in these areas in coming future.
And I think setting those priorities, we need to be thinking about that now, since we are heading into the new budget year. What are we going to do? I guess I grew up in an era where I like the theory, but I want to do something about it. In fact, someone said to me the other day, because I was asking about something that someone had told me, and I was saying, well, what are we going to do? And the person I was talking to said, oh, I told him not to tell you about it because you'd want to do something. And I think that's where we need to get. I think there's so many smart people here. There's so many great ideas. That's why I've stayed in academic medicine, because I love being able to have all those great ideas and be at the leading edge. But at some point, we have to stop and say, these are the things that we're going to do to innovate. And that's where I think that we need to be able to do a little bit better. I'm going to ask the final question, then we can open it up for other answers. But I'm going to talk a little bit about the costs and the things we've been doing around cost. And I think it was David or one person in our team said we really need to move beyond bringing down our costs to really thinking more. It should be bringing down the costs of caring for a person. And I think that's really what we've been trying to do with some of the work that has been supported by the Berkeley Research Group in the health system. So I'd like a little bit of thought around why, and I'm going to single out Gulshan to start, why is this cost imperative so important? I mean, why do we really need to listen to that, and where are the risks if we don't?
There's not enough money out there. So more money, more debt to U.S. economy. So you guys have seen it. If anything we're going to do, we got to do within our current means, and we are adding more patients or more lives in any healthcare system. So for example, if CMS paid $20,000 for a knee replacement, the range is anywhere $20,000 to $28,000 throughout U.S. So they are saying, hey, I got 40 million lives that we are covering. So I'm not going to pay $8,000 more. So you guys need to figure it out. Those areas where we are paying $28,000, that you need to get your cost down to $20,000. Otherwise, it's an elective surgery. We are going to move all these patients to these hospitals. So that's a concern. So we need to think about that, how much we are spending. So this is actual cost. This is not charges that, that we bill $20,000, CMS pays us $5,000. No, this is actual amount CMS pays us for a knee replacement. So you need to think about and partner with, I think, Cheryl and Becky mentioned during growth that how we are partnering with post-acute care SNF. That's why they want to bundle it. They said, you know what, we can't pay acute care hospital and you rush the patient out to post-acute care, and we pay post-acute care they are keeping patients 25 days and they are charging us X amount. So the total cost of care is very expensive in this region. So you need to figure it out how you want to work with post-acute care, and we want to just give you a set fee, and you decide whether you want to keep patient 10 days or 3 days and 7 days in post-acute care. And I think there are a lot of pilots and experimentation that is going on throughout US, and there are good results where they have very collaborative areas in terms of post-acute care and acute care. And I think we got to start working towards that. They are not going to give us more money for the same conditions. So there is not going to be that growth. So that's why it is important for us to look at volume too. So that's why we have the growth group that is looking at how we want to ensure more lives under UTMB. So if tomorrow somebody comes and cut the cost, where we are going to fill all that revenue to cover our expenses. So that's why it is so important for us to look at all those things that we are doing and appropriate and necessary for the patients.
I think as we look at the reducing the cost of care, there's a lot of what we've talked about today, I think, feeds into it. And you mentioned, Donna, how do we really do something to impact change? And part of what made Best Care and continues to make Best Care so successful is the focus that we have around the institution. Everyone, as we can see from videos, can tell how their work connects to Best Care. And I think that that's the rigor that we need to bring around reducing cost of care, because it's not just that your care is high quality, it's also that it's low cost, because a good patient experience also means you're not getting unnecessary tests or unnecessary consults. And I think that when we look at, you make a difference locally, we need to use that data to look at where our issues are. But also we need to think about maybe the revolution is in how do we shift our culture to have everyone thinking about reducing the cost of care. How do we empower at the local level a way to pilot and learn from those pilots ways to improve cost of care and drive the waste out, and not be looking at something that failed as a failure, but rather as how do we tweak it and move forward. And if we can do that and shift our culture in that way, I think that that gives us a lot of power to actually move forward in terms of reducing the cost of care.
First of all, I want to thank the 4 people around me, because it is a good team, and there are other of our team members sitting out in the audience that we work with every day, every Tuesday for 2 hours, really thinking about how do we need to change our care. One of the things that I'm struck by is what Katrina said. We are super successful when we're focused around something. I really think we as leaders, to help everyone understand what it is we need to do. We need to really prioritize now some of these efforts that are going to allow us to really make a change in how we care for patients. What I've really liked this year that I've seen, and I think that any number of us have been involved in it, is to take a certain type of care, whether it's a cabbage or whether it's a knee replacement. And now we're looking at it holistically, saying, where do we have length of stay opportunities? Do we have opportunities to reduce any kind of complication, which will add to the cost? Do we have opportunities to use different drugs, different supplies, different implants that would be a lower cost without compromising patient quality? And those are the things that I think when it really gets us to how do we really reduce the cost of care, and gets us beyond looking at, okay, well, let's take, the travel budget away, or things like that, that in the long grand scheme of things aren't really going to solve our issues. So the work that all of you have done is just terrific. The work that you all help us with is wonderful. We appreciate all of you so much, and what you contribute as a team to UTMB. So with that, I'm going to open for questions.
Thank you. Thank you. Thank you.
Thank you, Donna. I do have a question. You all spoke about technology and new ways of seeing patients. I think we all have seen the ad from another hospital saying now we do video visits. And I know that we're very successful in using telemedicine with our Hospital of Galveston and the CMC. Is there any opportunities for us to do that as well in this health system, or are there any barriers that we need to overcome that, to allow us to do that?
Yeah. So I'll take that one. We have been, we've been tinkering around with it, is what I would say. I think that TDCJ has done a wonderful job, and we could learn a lot from them, Annette. We have also done a pilot in ENT around discharge follow-up by televisit. We've also done some child psychiatry, which is hugely successful by televisit, especially into remote locations across our state where there's no mental health care. We've also done a very small pilot at UT System Austin with some of their employees. But we're behind. We're very behind. And what we've learned from the tinkering around in these experiments is that we can't put the telehealth responsibility onto the backs of already busy providers who really don't have the time to just do this part-time. We need a fresh approach. We need to start hiring clinicians, practitioners who believe in it, who do it well, and are very efficient at it. I think that we've tried to do it with current resources, and that has been at least one barrier that I've seen. We definitely have the technology, though.
The other barrier that I think that we can, well, a couple that we could overcome. One is just getting reimbursed by health insurers to do this type of work. I think it's coming to the forefront, and I think that that will change, but we need to, we definitely need to be ready for that.
I think it presents a really wonderful opportunity, and I do think that it's an opportunity for us to take something, honor the past, something that we're very, very good at, care for the patients today, but look at how does a televisit really help us move forward in the future. And as you mentioned, Donna, there are not very many ways we can get reimbursed for it. However, there are some populations that are willing to pay $40 for a telehealth visit and move on with their day.
I would.
And I think, it also represents, we talk about keeping patients outside of our clinics and outside of our hospitals. This is another wonderful touch point for that busy person who is willing to put their credit card in, get their visit, move on with their day, and keep going. And it could, for us as an institution, I think, represent an additional patient population that we perhaps don't reach today. And that's part of what we need to do as we think about the growth imperative as well, because we can't be successful in a value-based reimbursement environment if we don't grow the population we serve.
I think we overthink the risks in telemedicine as well, like, oh, there's so much risk involved. We're really talking about very measured risk. And in primary care, for example, we're talking about high volume, low acuity, it's very simple care, right? And so it's not high risk. Dr. Bardwaj, if we start doing neurology by telemedicine, maybe that's a different discussion. But I don't think that we need to overthink the risk, but think through the risk and still execute on it.
I actually had the same question, so I'll just piggyback on to that. This morning, driving in, I was listening to CNN, and I didn't see the video because I was in the car, of the physician talking to a patient about, end of life, not really in those words, but if they received morphine, they would stop breathing. And so it was a big deal because I think some of the caring wasn't translated, but and the patient died the next day. And so I think they said something about, what kind of physician is this that would do that? So are we preparing our patients for this wonderful technology that they could have a televisit and have someone see them more frequently, especially maybe at the end of life, where those decisions are harder because it's not going to end in a happy ending, like maybe someone walking in the hallway seeing Moxie and getting excited?
Yeah, I think, Dieter, I saw that it was in California. So a physician in California did that. So So that's why we have to be very careful how we are going to implement it. So I think we got to start slow. It's probably first, I think, would be outpatient and post-surgery, just show the wound that make sure that it's not draining and they don't have to come to the clinic. Those are the things that we are thinking of where we want to deploy. Palliative care is great if it is they're not able to have any access and they are very far removed from your facility, as long as there is enough discussion prior to implementing that. And I think that was an issue in this case in California.
I think we have an opportunity to, every interaction we have with the patient is an opportunity to create trust and brand loyalty with UTMB.
Yes.
So can we learn from Amazon how they've created brand loyalty with Amazon Prime, where they lose money on their next day shipping, but they find out what the customer really wants and they get it for them? Can we use every interaction, whether it's virtual or in person, whether it's on a billboard or whether it's talking on a podcast, how can we create that trust and brand loyalty with our patients?
Everybody who came today, who sat through this, we are excited about the future. We're excited about the leadership, I think, that UTMB already is providing. I know all of us get questions from our colleagues around the country more and more. How did you do that? And the answer to it almost always is we prioritized it, we focused on it, and we worked as a team to make it happen. And so I appreciate being part of the health system team. I appreciate us all being part of the UTMB team, because I think that collective, I'll call it brain power that we have, and our willingness to really roll up our sleeves and do something about it is really going to position us well for the future. So thanks to all of you for everything you do every day to make UTMB a better place for patients to receive their care.
Thank you.
UTMB Health, working together to work wonders.